Hello, everyone. Welcome to the Department of Psychiatry and Behavioral Sciences Grand Round Series. My name is Joe Caramelli. I oversee Grand Rounds for our department. I have learned from others that there, at some of the sites, there's groups of people getting together in rooms to watch Grand Rounds. I think that's great. I think it's a good opportunity to come up with questions or comments as a group, and whoever logged in there could type it in, and we'll try to have some time at the end for comments or questions. I encourage you to write those into the chat or Q&A. I can monitor those during the presentation and go through those at the end. There is a group of us that works on Grand Rounds throughout the academic year, including Semhar, Brandon, and Charles on different aspects of the series. A couple of different sources of funding for this year's series, including the Ripley Fund, the Garvey Institute for Brain Health Solutions, and as an example for today's presentation, the Treatment of Mood Disorders Fund. And with that, I'll tell you about today's presenter, Dr. Danella Haifman. Dr. Haifman is an associate professor of psychiatry at the University of Pittsburgh School of Medicine. And I do want to emphasize Dr. Haifman is a physician researcher with clinical and research interests broadly in children, adolescents, young adults with mood disorders. And I'll make a point that last week here at UW was the Psychiatry Resident Scholarship Research Day. So important to think about the trajectory accomplishments of physician researchers. And here, Dr. Haifman serves as the medical director of the Child and Adolescent Bipolar Services Outpatient Clinic, seeing patients clinically in the area where she's also doing research. Dr. Haifman's research has covered really a couple of areas, several areas in the domain of youth, young adults with mood disorder symptoms, including, interestingly, working on the Pittsburgh Bipolar Offspring Study to develop a bipolar disorder risk calculator in children of individuals diagnosed with bipolar disorder, which I think is a point that we'll hear more about during today's presentation, and intervention studies. So understanding risk, understanding epidemiology, and then treatments for youth who are at risk for bipolar disorder or with mood disorder symptoms. I mentioned a little bit about physician research. I want to note that Dr. Haifman also directs the psychiatry resident research pathway and has a strong interest in mentoring individuals, including medical students and other trainees in clinical research. So I think I'll end there, and I'll turn it over to Dr. Haifman.
All right. Thank you so much, Dr. Caramelli, for the introduction and also for the invitation to present. I'm excited to be here today. Let me just pull this up. Getting all my screens set up. All right. I will be talking today about some of the work we've done over the past decade, really looking at person-level risk prediction of bipolar disorder in youth. And that'll be kind of a launching point, and then I'll talk about some of our newer work and interventions. So I don't have any conflicts of interest. So I want to make sure we're all on the same page first. So I'm going to talk a little bit about the diagnosis of bipolar spectrum disorder, particularly in youth, both definitions and epidemiology. And then I'll go into the bulk of this will be some of our work in early identification, predicting bipolar onset, and this risk calculator that Dr. Caramelli mentioned. And then finally, treatment implications for at-risk youth. So lifetime prevalence of bipolar disorder in youth is actually very similar to what we see in adults. 0.6% was an estimate from a meta-analysis by Anna Van Meter in 2019, which is essentially identical to what we see in adults. And then bipolar spectrum disorder at 2.6%, which is also within that range. And this isn't surprising because the median age of bipolar onset is 15 to 19 years old. So, there are different peaks, but if you look at kind of the strongest peak, it's during that late adolescence. And, for child psychiatrists, the earlier onset is associated with poor outcomes, more substance abuse, a worse mood course, and more prevalent suicidal thoughts and behaviors. So it really is a disorder that is within the wheelhouse of child and adolescent psychiatrists. Unfortunately, though, it may not always seem this way, and this is because delays in diagnosis and treatment are really common. So, this was from a meta analysis by Degani in 2017, and it was Canadian. And the average delay between the onset of symptoms and then diagnosis was almost 6 years. And unfortunately, one of the predictors of having a longer delay was having this younger onset. And this is really problematic because when you think about the period of time of this delay, it's high school, college, forming important relationships, trying to meet developmental milestones. And so it really is critical that we try to recognize bipolar disorder earlier to avoid treatment delays during these really critical developmental periods. And so, we'll be talking about sort of early markers of risk, but fundamentally, for me, this is the goal that we kind of push the bar back so that we can hopefully intervene for people when it really counts. Okay, I want to talk a little bit about bipolar disorder in youth and the epidemiology, and that's because I think there have been some misconceptions over the years. Mostly, I think these are, in the past, but just so that we're all on the same page, there's been a myth that pediatric bipolar disorder is a US phenomenon. And actually, when you look across studies, there's no difference across countries. There was an idea that rates were increasing a lot over time. And there were increases in the number of diagnoses, but actually, if you carefully assessed, there was not this increase in rates over time. However, the definition of bipolar spectrum disorder is the most important predictor of prevalence. And so, it's about how sort of broad we're defining that. And so, just to get on the definition of what we mean by bipolar spectrum disorder, I'm going to just show the following slide. So really, when we're talking about bipolar disorder, and this is bipolar 1, bipolar 2, or other specified, we're really talking about a condition that is defined by episodic nature of symptoms. And in particular, on this end of things, the sort of mania, hypomania end of things. And so, I'm sure most of you know the criteria, but essentially to have that sort of mania, hypomania, you need an elated or irritable mood, plus increased energy, and then 3 of these additional symptoms. And so, these things are clustering together. They're different from baseline, things like increased self-esteem, decreased need for sleep. It's interesting because, some of these, or I would say most of them, overlap with other diagnoses, right? So, for instance, I have ADHD up here, and many symptoms of ADHD could overlap with symptoms of mania. We have being more talkative, distractible, impulsive. Those are all parts of ADHD too. The difference is, though, in addition to probably not having these criterion A symptoms, you're not getting the episodic nature. Maybe there's small fluctuations according to the environment, but not the same sort of spontaneous episodicity. So there was a question from, I'll call it the early 2000s now, if chronic irritability is bad enough. So if it's really explosive and energetic, is that a symptom of bipolar disorder? I think there's been a lot of work done at this point, and the answer is essentially no. It's different epidemiology. The kids who have this explosive irritability don't necessarily go on to develop bipolar disorder. The caveat is important, though. It's not that kids with chronic symptoms can't have bipolar disorder. And in actuality, bipolar disorder is highly comorbid with a lot of these other disorders. But what we're looking for is something on top of that. So having, in addition to whatever they have already, this spontaneous episodicity and temporal clustering of these manic symptoms. Another question has been whether sort of the bipolar diagnosis in childhood is actually the same thing as bipolar diagnosis in adulthood. And so we actually took a look at this, and this is important, right? Like, are we talking about the same bipolar disorder? So I was interested in taking a look at this in our longitudinal study of bipolar youth called the Course and Outcome of Bipolar Youth. And we asked whether children diagnosed with bipolar 1 or 2 continue to have mania or hypomania in adulthood. So essentially, we assessed the continuity of diagnosis, and this was for kids with mania or hypomania, threshold bipolar disorder, from childhood to adolescence to adulthood. And this figure is a little bit complicated, but I'll walk you through it. So we had a certain number, 189, who were diagnosed prior to the age of 13. So there's sort of this prepubertal diagnosis. Of those, about 60% continued to have mania or hypomania in adolescence. And then of those who continued, 40% had mania or hypomania in adulthood. This 40% number was very similar to what we saw in the adolescent onset of 46%. So it's not that it's 100%, it's not that everybody who has it in childhood is going to have it in adulthood, but there is enough continuity that it does seem to be the sort of same underlying illness, as long as you're really looking at this episodic nature. Of interest, if they didn't have mania or hypomania in adulthood, only 7%, or sorry, mania or hypomania in adolescence, only 7% have that in adulthood. All right, so that was mostly to get us on the same page of what we mean by bipolar disorder in youth, given just sort of the history and different definitions. So let's talk about prediction. And I like to start off with a clinical case. A 10-year-old girl walks into your office. She's presenting with irritability and depressive symptoms. So, pretty nonspecific, common complaints. But her mom has a diagnosis of bipolar 1 disorder. And so often with parents like this, they're concerned, like maybe, oh, that's what I was like as a kid. Is she going to develop this too? And so the questions are, what are the girl's risk factors for conversion to bipolar disorder? What should we be assessing and maybe intervening on? And then what is this girl's risk of conversion to bipolar disorder, which is a bit of a different question that we'll go into. So when we started this work, over a decade ago, one thing that was clear was that bipolar disorder rarely comes out of the blue. It does sometimes, but more often it's preceded by a variety of different symptoms. We can call these prodromal symptoms or antecedent symptoms. Some of them could be around for, weeks to months, but maybe even years. And so, a lot of both retrospective studies and also studies of offspring of parents with bipolar disorder showed a variety of symptoms that may be prodromal to bipolar disorder. But the issue is that this is very nonspecific, right? We have internalizing disorders, externalizing disorders, sleep and subsyndromal mania. And so, the question is whether we can identify a more specific prodrome. And that's really a key step to both that timely diagnosis that we were talking about before, and also early intervention. Who do we need to be intervening on? Who would benefit from more bipolar specific treatment? So the analyses I'm going to present to you next come from the Pittsburgh Bipolar Offspring Study, or BIOS. And the main PI of this has been Boris Birmacher, who is one of my main mentors as well. And this was all, I kind of came in at the sweet spot of this study because it had been going on for a long time, and then got a chance to analyze all of these data. But it was initially a case control high-risk study, so looking at offspring of parents with bipolar disorder versus offspring of community controls. And then there was longitudinal follow-up. And by the time it was finished, it was more than 10 years of follow-up. The participants were 235 parents with bipolar 1 or 2 and their offspring, and then 141 community control parents and their offspring. And participants were assessed approximately every 2 years, and they were also, they had salivary samples collected for genetic analysis, which I'll also be talking about today. There was also neuroimaging data that we've also analyzed, but I'm not going to be discussing that today. So this first figure from one of the main BIOS papers from about almost 10 years ago now, really shows that the most important predictor of bipolar disorder is having a family history. And we kind of knew that going into BIOS. That was the rationale for doing the study. But, it really pans out quite clearly. So the top graph is the percentage with bipolar spectrum disorder, bipolar 1, bipolar 2, or other specified. And you can see that the comparison offspring in orange have about a 3% rate by the time of adulthood, which is, consistent with that meta-analysis that I showed before. And no prepubertal onset. I mean, it's essentially a flat line there. In contrast, the high-risk offspring, they start developing bipolar disorder much earlier, and by adulthood, it's approximately 25%. We see a very similar pattern with onset of mania and hypomania. It's just the numbers are a little lower, about 1%-ish in the comparison, and then 12 to 13% in the at-risk offspring. So, 25%, that's hefty and really shows that this is a risk factor, but it's not 100%. 3/4 are not developing bipolar disorder by adulthood. And so the question that we really had was, well, what differentiates those who will develop bipolar disorder versus those who won't? And so we wanted to look at this from a dimensional analysis perspective. So all of these questionnaires that people were filling out, what mapped on best to this diagnosis? And so this slide shows kind of how we did the analysis and all of the data that we had. We had a bunch of questionnaires from the parent report, the child report, and also clinician assessments of depression rating scale and mania rating scale from the Kitty SADS. We essentially did 4 different factor analyses to try to decrease the data a little bit. So we weren't looking at, every single questionnaire. And then we asked, well, which of those are predicting bipolar disorder? And to do that, we did a penalized regression, lasso, which selects which are the most important predictors. So this was what our population looked like. At baseline, we had 33 offspring of bipolar parents that already have bipolar disorder, so they couldn't really be included in the analysis. These are the 220 control offspring, not really, interested so much in them for these purposes. But these offspring of parents without bipolar disorder, these are the ones we're interested in. So over this paper now is from 2016. So at that point, there was 8 years mean follow-up. And 44 of those developed new onset bipolar disorder, while 255 didn't yet. So the question is, what differentiates those who developed disorder from those who didn't? And you can ask that in a few different ways, right? You could say, well, when they came into the study, even if it was years prior to developing BD, what were the predictors? And then you can ask, well, how about the visit prior to the onset of bipolar disorder? What were the predictors then? And so this next figure summarizes all of those results, and I'll walk you through this. So in the green, we have the predictors that were selected at baseline. So these included affective lability, which is frequent and strong changes in mood over time. And it's based on the child affective lability scale. So asking things about mood switches during the day, you never know what mood your child's going to be in, those types of questions. Anxiety and depression was an earlier baseline predictor as well. And then this parent age at mood disorder onset popped up. So the younger the parent when they developed mood disorder, the more likely the child is to develop it. So those were the baseline predictors. Proximally, it was a little bit of a different story. So obviously, parent age at mood onset is really both baseline and proximal. But in terms of symptoms, affective ability was still important. But now we don't see anxiety and depression. Instead, what we see are these subthreshold manic symptoms. So not meaningful criteria for bipolar disorder, but having maybe some increased energy, some decreased need for sleep. So starting to sort of brew the mania hypomania that would come later. And so another way of looking at this is the symptom time course. This is anxiety and depression. And this shows the years till proximal assessment for those who develop bipolar disorder in red and those who didn't in blue. And you can see that like earlier on, it's separating more, but actually closer to that point becomes less sort of prominent. Affective lability, on the other hand, is also separating earlier and continues to separate. And then we have this mania rating scale. And so earlier on, it's really not separating at all. And it really starts to separate at the proximal assessment, so about 2 years prior to, or less, prior to the onset of bipolar disorder. So this led to the sort of idea of a staged model of the bipolar prodrome. And this staging of 1A, 1B, 2, that's not ours. That's from McGorry, initially for psychosis, but also modified by Burke for bipolar disorder. But what we did was say, okay, well, what are the non-specific symptoms here? And those include things that are present very early, right? Anxiety, depression, mood swings, and really could be going in a lot of different directions. Stage 1B becomes this more specific prodrome, closer to the onset of bipolar disorder, more similar sort of the same ilk of mania, hypomania, and then leading to the development of bipolar disorder. Now, not that this is, perfect, right? I'm sure people with hypomanic symptoms also develop other things, but it's this idea that you're sort of getting closer and closer to that diagnosis. So back to this 10-year-old girl, as her psychiatrist, what are you going to be paying attention to? Well, one, early anxiety and depressive symptoms are a predictor. So, following those over time. Mood lability. So we talked about irritability, but the question is, are there a lot of mood changes throughout the day? Are these all related to stresses, or does it just seem like you never know what mood she's going to be in? And then over time, this development of subthreshold manic symptoms. Now, that's important because it's not that, you assess it at intake and that's one and done, right? Like, it's important to continue to assess for that over time, especially as she gets more into the risk period, right? More into that 15 to 19-year-old range. And all of this is especially true if the mother developed a mood disorder in childhood and adolescence. And I've been, definitely asking more for parents about when their disorder onset, not just to see if they actually have bipolar disorder or not, because it really does impact risk. Okay, so far we've really been talking about population level risk factors, sort of this idea of which risk factors on the population level increase the chances that someone develops bipolar disorder. So we've got anxiety, depression, mood lability, subthreshold manic symptoms. This is how we usually think about things in psychiatry, and it's very useful for identifying things like, for instance, mood lability as maybe a treatment target or other preventable causes of disorder. And we need to know enough about what are the risk factors to start to develop more individual level models. But I would argue that for the clinician, the person level approach is perhaps the most important, because that helps you inform the prognosis and treatment of the person sitting across the table from you. And so the question for the more person level model, in this case, is given the risk factors, what is this individual's risk of a given outcome? So in this case, bipolar disorder. So that's where a risk calculator comes in. It allows you to ask that question of how likely is it that an individual child or adolescent with an affected parent will develop bipolar spectrum disorder. And so to get from population risk factors to estimated person level risk, for instance, her risk is 30%, we use a risk calculator model. And for those of you who grew up in the 80s, you probably will recognize this as a calculator. Those who didn't may not recognize it, but I assure you our calculators are a little bit more sophisticated than that. Risk calculators are used quite a bit in other areas of medicine and have also been developed in psychosis. And in other areas of medicine, for example, cardiovascular disease, sometimes these risk calculators, like the Framingham risk calculator, are used to help inform whether somebody should go on a statin or what kind of intervention would be indicated and appropriate. So how did we develop the risk calculator? Well, we had 412 at-risk offspring, and which is more than the initial sample you might recognize. So we actually added some people to this. And then 54 developed bipolar disorder. How do we choose the predictors? So, I mean, we could just say, oh, well, those factors, right? They predicted, let's just see how well they predict. You can't actually do that because that then overfits the sample. And so you may be able to say a lot about this particular sample, but it may not actually generalize to other samples. So we were fortunate that there was a meta-analysis that was conducted in 2017 that asked the question and it was mostly retrospective, what symptoms occurred prior to a bipolar disorder diagnosis? And so essentially what we did is took the list of symptoms that were either somewhat common or very common and mapped them on to the questionnaires that we had used to assess them. And so what we ended up with were a lot of manic symptoms. A lot of the symptoms that were listed in this meta-analysis were also in the were manic symptoms. Some depressive symptoms, anxiety, mood lability, global functioning, and then we also included offspring age at visit and parental age at mood disorder onset. So again, we have this 412 at-risk offspring, 54 developed bipolar disorder. How did the risk calculator do? Well, the accuracy was pretty good. It was an AUC of 0.76, which is certainly far from perfect, but actually on par with many of the risk calculators that are used in medicine. And just to give you sort of an idea of what this area under the curve or AUC means, essentially, if you have one individual who will develop bipolar disorder and one who won't, this is the percentage of time that the model classifies them accurately. And so, if you are omniscient, then the AUC is 1, chance is 0.5, so 0.76 is somewhere in the middle. And this is what that looks like in a figure. So first we can look at the non-converters that are in light blue. And this is their 5-year predicted risk of bipolar conversion. So you can see that many of them have quite low risks. Most of them have less than an 8% predicted risk of bipolar disorder conversion in the next 5 years. That's in contrast to the dark blue. Some of them have this lower risk, but many of them have this sort of 8 to 12% and then up to greater than 20%. And so you can see that, above 8% or so, the converters are more likely to have those level of risk, whereas below 8%, it's the non-converters. So again, not perfect, but better than chance. And these are just the predictors that we tested and how they did. So, one important thing from this figure, if you look at the univariate 5-year AUC, this is how well each of them would do by themselves. And so almost all of them, except this offspring age visit, did quite well by themselves, although not 0.76 well, but did reasonably well. If they're removed from the model, the question is, well, what is the decrement to the AUC? How much do you lose? And here you see that you don't lose a whole lot. Parental age at mood disorder onset, you lose 0.05, but these other ones, it's very close to 0. And even that one isn't significant. So the take home here is that all of these are predictors, but there is some redundancy in this risk calculator, so that if you remove a single variable, it's kind of accounted for by the other variables, which means that it could probably be a bit simpler than it is. Okay, so what are the clinical implications? Well, this risk calculator is available on our CABS website, pediatricbipolar.pitt.edu. You are welcome to go and check it out. The instruments are also available, and enter in some different scores, see what you find. It has not been externally validated yet. So we did internal cross-validation, but the gold standard is really to externally validate in another sample. And so it's important to know that, it can't be used with confidence clinically until that happens. Now, so far we've talked about sort of the risk calculator in an at-risk sample of offspring. One recent project we did actually with Anna Van Meter was trying to apply the risk calculator to a clinical sample, since that's really what we're more interested in. We're more interested in the people who are coming into clinic. And so to test this, we looked at the LAM sample, or longitudinal assessment of manic symptoms cohort. which include 473 youth that were recruited from clinics, and they were recruited preferentially for having some manic symptoms, and 65 of them developed bipolar spectrum disorder. And I'm not going to go through our whole methods and results in the interest of time, but I will show you our model outcomes for training in BIOS and then testing in this new clinical sample. So the one that does the best is actually not the full model. So the full model is up here with mania, depression, anxiety, functioning, and age. That does not do so well. What does better is just the MRS and DRS screening items, actually, plus age. And so the take home here is that simpler may be better, and especially in a clinical sample where things like anxiety and global functioning are kind of red herrings, right? Like they can be found in, they're quite non-specific. And so in that sample, it may be that more sort of mood disorder specific predictors do better. Again, this would have to be externally validated in another sample. Okay, so switching gears a little bit, we've been talking a lot about clinical markers of risk and then, putting those together into a risk calculator. So what can we say about an individual's risk? Now we're going to switch gears a little bit and talk about a biological marker of risk, which is polygenic risk score. And I'm sure most of you have heard about polygenic risk score at this point, but I just want to kind of go through a little bit about what it is so that we're all on the same page. So polygenic risk scores are developed from large meta-analyses of what are called genome-wide association studies. And so, for instance, the most recent the polygenic risk score for bipolar disorder by Mullins et al. Had 40,000 participants with bipolar disorder and over 100,000 controls. And so what this allows you to do is look across the genome, which is here, and look at variants that have very small effect sizes, but are reliable across samples. So you get a more robust estimate of very small effects. Because it turns out that risk is distributed across the genome. It's not just in a few spots, but it's very difficult to really assess that in a small sample. So what these large samples give you is a reliable Manhattan plot, which shows you what the risk variants are. And the skyscrapers are those with the highest level of risk. So then what you can do is for a given p-value threshold, say I'm only going to look at buildings taller than 5 stories, essentially. So more significant than a certain p-value. And then you can take a weighted average of these risk variants and get a polygenic risk score. And so, if you give blood or saliva and they and someone does this analysis, they'll be able to say, well, your risk of developing this disorder is 8%. It's your polygenic risk score, for example. Now, the nice thing about polygenic risk score is it is normally distributed in the population, with most people having this sort of intermittent level of risk, and some quite low risk, some quite high risk. And so now when you have this sort of polygenic risk score calculation based on, large samples, very robust assessment of these effects, then you can apply it to a new smaller study like BIOS. And essentially what we're doing is leveraging the meta-analyses to apply in a reliable way to a smaller sample. And that's been, done by several people so far. Here's just a smattering of those results. These are all in adults with bipolar disorder and their relatives. So Catherine Musliner et al. Found that within adults with major depressive disorder, higher BDPRS predicts onset of bipolar disorder. BDPRS has also been found to be elevated in bipolar disorder compared to both healthy controls and at-risk relatives, and then higher in those with a family history of bipolar disorder than in healthy controls. And so really, kind of indicates that this may be sort of an endophenotype, higher in the at-risk, but higher still in those who convert. But before the analysis of the BIOS data, there really was very little about youth with and at risk for bipolar disorder. So that's where BIOS came in. So how did we assess polygenic risk score? We collected salivary samples of both the parents and the offspring. And then with our colleagues in Halifax, Rudolph Uher and his graduate student Allison Zwicker, calculated the polygenic risk score based on this meta-analysis of GWAS that I showed you before. And this included 251 at-risk offspring, 38 with new onset bipolar disorder, and then 158 community control offspring. Now, if you're paying attention, you might notice these numbers are a little bit smaller than what I talked about for the risk calculator. And that's because, unfortunately, at this point, the largest and most reliable GWAS meta-analyses have been conducted pretty much exclusively in individuals of European ancestry. And so because of population stratification, you just can't use a polygenic risk score developed in one population and assume it's going to work in another. It just doesn't work as well because of population stratification. So we only included individuals of European ancestry in this analysis, unfortunately. And next, we assessed relationships between polygenic risk score and bipolar disorder risk. And then what I was really interested in, was incorporating this into the risk calculator. So if we added this to the clinical predictors that I showed you earlier, could we improve risk? And so this kind of goes into some of the methods we used. We used a lasso regression because what we wanted to see is not only were the clinical predictors and polygenic risk score predictive and how predictive, but also were some of the interactions predictive. And there is some evidence that polygenic risk score may predict better in certain populations than others. And then we did an internal cross-validation with 1,000 bootstrap resamples. So first of all, we looked at the polygenic risk score in offspring of parents with bipolar disorder, the 251 here, compared to the offspring of community controls. And the basic message here is that the BDPRS was elevated substantially, significantly in the offspring of parents with bipolar disorder. And that was significant, or was specific to the BDPRS. We did not see this in the PRS for major depressive disorder or for schizophrenia or for ADHD. So this figure is a little bit complicated and essentially looks at how the parental polygenic risk score is sort of propagated to offspring polygenic risk score and then offspring bipolar disorder risk. And I'll walk you through sort of the key findings. So first of all, polygenic risk score predicts bipolar disorder in both the parents with an odds ratio of 1.4 and the offspring hazard ratio of 1.4. So very similar effect sizes, which is good. I mean, if that wasn't true, then probably it wouldn't be such an important predictor. The offspring BDPRS mediates the effective parent BDPRS. And so that's shown here that it's highly significant between parent and offspring. And then that mediates the polygenic to offspring bipolar disorder risk. This direct effect of parent polygenic risk on offspring bipolar disorder is not significant. And then finally, the family history not explained by BDPRS, so this line right here, is still the strongest effect. So even with all of this, polygenic risk score, interesting findings, it still doesn't explain that finding I showed you from the beginning of the bio study, which is that family history is the most important predictor. Okay. So the next thing we wanted to do was add the polygenic risk score for bipolar disorder to the risk calculator. And this figure shows the results of that. So these are all the predictors that I showed you before, although now we're using a lasso regression, so only selecting those that substantially predict from baseline onset of bipolar disorder. And so, you can see the age, parent-mooted onset age, those two things predict. The other thing, the thing we were most interested in, is whether BDPRS and its interactions would significantly predict, and whether the removal of them would decrease the area under the curve. And so, in fact, we found that that the PRS improves person-level risk prediction in at-risk youth. So without BDPRS, the AUC was 0.74, and with it, it was 0.81. So that maps on to this decrement, right, going from 0.81 to 0.74. And that was the bootstrap p-value was significant. So what's interesting here is that, it's not just the BDPRS, but it's also how it interacts with parent mood and onset age, depressive symptoms, and anxiety. And so next we wanted to kind of take a look at that. What do those interactions look like? Who, is kind of most affected by a high BDPRS? What sort of symptoms make BDPRS more important? And so let's start with a take home here. BDPRS has a larger effect in youth with anxiety and depressive symptoms at intake, and a parent who develops bipolar disorder earlier in life. So if you look over here on the left-hand side, if you have late parental onset, and so late parental is greater than 18 and no symptoms below sort of the mean, there's very little effect of BDPRS. It's pretty much, it is nothing. In contrast, if you have both early parental onset and also depression and anxiety symptoms, then you get this pretty marked effect of BDPRS. And, the middle groups are kind of intermediate. So essentially, BDPRS is more predictive in those who already have some symptoms and also have this earlier parental onset. Okay, so now to summarize the second part of my talk, these longitudinal studies of offspring of bipolar parents, I think have led to improved understanding of bipolar risk trajectories. We've developed a risk calculator that can predict with good accuracy the development of bipolar disorder in both familial at-risk and clinical samples. And new genetic findings provide evidence for biological underpinnings of familial transmission and pediatric bipolar disorder. And finally, BDPRS is really not clinically meaningful alone, but it may interact and add with other variables to improve risk prediction. Okay, so finally, and I realize that we are kind of short on time here, so I may have to skip through some of this, but in terms of treatment implications for at-risk youth, I want to show you a little bit of our data on mindfulness. Basically, the question is, how does risk status inform treatment? And there are several evidence-based psychotherapies for symptomatic youth at familial risk that have at least some evidence. Family-focused treatment from David Miklowitz, multifamily psychoeducational psychotherapy, and interpersonal social rhythms therapy that is a treatment for bipolar disorder in adults that also has some evidence for sort of improving the course of youth who are at risk for bipolar disorder. But given the findings from BIOS, we thought that an intervention to target mood lability, since that is both baseline and proximal predictor, could be helpful in these youth. And the intervention we chose was mindfulness. And this is in part related to this meta-analysis that showed that some of the more robust and significant effects of mindfulness intervention in youth is really this emotional or behavioral regulation piece. And that's substantial and highly significant in both pre-post and controlled studies. So given the effects of mindfulness interventions on emotion regulation, could this target mood lability in at-risk youth? So our sample included 20 10 to 14-year-old youth at familial risk who also had mood swings, and 15 healthy controls as a comparison. And the protocol focused on the at-risk. There was an 8-week mindfulness group. Each group was about 60 to 90 minutes long and really focused on practices to enhance sort of this non-judgmental present moment awareness. There's an fMRI collected both pre and post intervention, including an 8-minute resting state. And then the healthy controls also had a sort of 2 MRIs 8 weeks apart. And then there was also a 3-month follow-up. So the mechanism that we were most interested in was this one, which is shown by initially by Judson Brewer in 2011. And they found that meditators versus controls showed increased functional connectivity between the posterior cingulate, or PCC, and the frontal parietal control network, namely the dorsolateral prefrontal cortex. And following this finding, there were then several studies that found that interventions in various populations increase this functional connectivity. So there was a study of stressed adults back in 2016 that found this increase in the mindfulness group. A study of adults with PTSD that also found a similar increase in functional connectivity. And then in healthy adults, similarly, MBSR, which is a mindfulness intervention, associated with increased functional connectivity relative to the other 2 groups between the posterior cingulate and this sort of target region of interest, which was the DLPFC. So it's really interesting, this sort of convergence of these findings. And so the question is, well, what does it mean? And so our idea, and what we're testing in a larger study right now, is that it may be related to this sort of awareness of mind wandering. So essentially what mindfulness-based interventions do, it's a practice in recognizing that the mind is telling stories. Our minds have a tendency of, going to the future, what's going to happen next, or going to the past. Why did I say that thing? And not being in the present moment. And mindfulness is this sort of process of mind wandering here, which is really involved, the posterior cingulate is really involved in that. And then this becoming aware, which is the salience network. And then making that choice to shift and focus back on the present moment. And so the idea is, if you're practicing this over time, that's increasing the functional connectivity between these regions. At least that was the hypothesis of our grant. And how can that impact sort of emotion dysregulation? Well, it turns out that mind wandering, especially without awareness, and especially if it's negative, can really lead to this sort of ruminative emotion amplification and emotion dysregulation. And so it may be that sort of being able to be aware of that and refocus the attention could lead to an improvement in these symptoms. And just to go through this fairly quickly, in all of the studies I just showed you, plus one, the SCULTS study, this increased functional connectivity between the posterior cingulate and DLPFC was associated with improved outcomes, less inflammation, fewer depressive symptoms, improvement in PTSD, and improvement in self-reported attention. And it was also correlated with the structural integrity of a white matter tract called the superior longitudinal fasciculus. Okay, so that's what we were looking at in BEAM. These are the study characteristics of BEAM. I'm not going to go into this too much. What I will say is that this was, by and large, a clinical sample. So even though these kids were at risk, many of them were already having symptoms, and most were already in treatment. To go through our clinical findings, just one quick caveat, of course, this was not controlled. So these are just pre and post. And so we don't really know if they're related to mindfulness. But we had our overall effects, looked at the pre-post, and then the sort of later effects, because there's some evidence that mindfulness actually has more effect kind of later into follow-up, so post to 3-month follow-up. Essentially, we found significant effects with mood lability, anxiety, increases in mindfulness, and decreases in emotion suppression. In terms of this neural target, again, we looked at this posterior cingulate seed, and we asked, did the mindfulness intervention increase or change the functional connectivity between this PCC seed and any part of the brain? And we found that it was increased between PCC and this left DLPFC region, and that was highly significant. And this just shows the blue line are those that had the mindfulness-based intervention. So those were the at-risk youth. And then the healthy who didn't have any intervention are essentially flat here. And what's more, we found that those, similar to other studies, those functional connectivity increases predicted clinical changes at follow-up. So the more this function, the higher this functional connectivity change, the less mood lability, the less emotion suppression, and the more mindfulness. And again, these are fairly small effects, they're significant, but not super significant. But given that this was a small pilot study, really sort of set us up to do the larger randomized controlled trial. So in conclusion, our pilot data indicate that mindfulness-based interventions may decrease mood lability and improve emotion regulation via this functional connectivity of the posterior cingulate and DLPFC. Of course, many limitations to this study, small sample size and no control group. And we're very excited to have NIH funding for a larger R01 to test specific effects and mechanisms of a mindfulness-based intervention in a randomized control study. So this is the overall model that we're testing, whether this increased awareness of mind wandering tested both behaviorally and neurally leads towards a mechanism that explains this decreased mood lability. Okay, so take-home messages. I hope I've convinced you that it is important to assess for bipolar disorder in youth and to only diagnose youth who are showing this spontaneous episodicity and clustering of manic symptoms. Important predictors of bipolar disorder in at-risk youth are anxiety and depression, mood lability, and closer to onset subthreshold manic symptoms. We have this risk calculator to predict bipolar disorder on the person level, and polygenic risk score may improve that risk prediction. And early interventions, for example, mindfulness-based, have the potential to target antecedent mood symptoms. So with that, I would like to thank the overall CABS research and clinical team. Also, all of our participants and families, without which none of this would be possible. Various collaborators and staff. It really takes a village to do all of this, and funders. And with that, I will take any questions that people have.
Well, Dr. Hafen, thank you. What a presentation here, going through epidemiology, debunking some myths as well, thinking about risk, population, and individual, helping us all understand that in detail. And then from an individual, observe risk going on to an intervention. It's very informative, and I think has helped a lot of us think through this in more detail, and a model for a progression of clinical research. Thank you for presenting today.
Thank
I want to
you.
encourage any participants to write in comments or questions. I will pose maybe one question just to get things started with a couple of minutes we have. I wonder to what extent, if any, antidepressant exposure or treatment is involved in risk, if that's been measured, or what you've observed with that.
Yeah, it's a really challenging question, because we know that people who are getting antidepressants, it's because they're anxious and depressed, right? And so there's huge, what we call confounding by indication. And also some people with bipolar disorder, we talk to these parents and they're like, yes, I have bipolar disorder, and yes, Prozac has worked great for me, right? So it's not sort of a one-to-one issue. I mean, I do hesitate to say, oh, if it's at risk, then you should not use an SSRI. I mean, I will use antidepressants in at-risk youth. I will very much do a lot of psychoeducation with the parents and the child, depending on their age, and monitor them more carefully than I would just like your average person, because the risk is higher. Now, whether the antidepressants are precipitating the onset or causing it, I mean, these are much more challenging questions. I think, even having this sort of activation with antidepressants, if it stops once you stop taking the antidepressant, right, it's not necessarily bipolar disorder, but it certainly increases the risk. So, I think I think that there is no definitive data about that. I still will do antidepressants as first line, especially for anxiety. And these kids should say, I should clarify that as medication first line, therapy is first line, but if we need to add a medication, so.
Yeah. Complicated issue.
Yeah.
But just like diagnosis, it's also complicated. So, um, yeah, so others are asking if there's about, I guess, any treatment early on, if there's role for chronobiologic treatments, neurostimulation. This might be getting sort of beyond first line, or maybe not. I don't know. What are your thoughts on those domains of treatments?
Yeah, so asking about things like TMS
TMS, maybe changes, sleep regulation,
and
restriction or promoting, or light exposure,
yeah,
bright light therapy. Yeah.
right. So regarding sort of sleep, we know that's really important. And IPSRT, for example, interpersonal social rhythms therapy, which was developed for adults in bipolar disorder, really targets that kind of sleep and social rhythms and can really stabilize a lot of people. And so there's some promising data from Tina Goldstein, who is one of my collaborators from the initial randomized controlled trial, that this may help with manic symptoms. And then there's an ongoing, larger, hopefully definitive randomized controlled trial now. So we'll be able to say more about that. But for sure, sleep is important. I think in terms of other kind of stimulation and bright light, I mean, light therapy can be helpful for bipolar depression for sure. And TMS has good data in adults, less good data in adolescents for a number of reasons, better data for depression than bipolar disorder, but we don't know yet. I mean, potentially something like that could be very helpful.
Dr. Hafman, could you, we all tolerate some degree of uncertainty in clinical practice. When you're talking with families or with the youth themselves, do you quantify sort of your degree of, well, I think it's this likely you might develop bipolar disorder? Do you discuss that explicitly, or how do you manage that clinically?
Yeah. I usually don't say a number with a patient because I just feel like we're not quite there yet. In my notes, I definitely consider overall risk and have sort of like a feeling of whether this is high risk or not based on a lot of these symptoms. So essentially, I don't use the risk calculator in clinical practice yet. And I think it's a really interesting question about how it would be best used. Do some parents want to know this is the risk, or is it used more to sort of stratify according to treatment? So if you have over this risk, then you should go get, IPSRT because that could help with, the overall trajectory. So I think that gets at a lot of questions about whether this is ready for clinical prime time. And then, how do patients and families want to receive this information?
Interesting. A couple of next steps in research.
Absolutely. Yeah.
All right. There were we didn't get to these. Several other questions came in about, should we use lamotrigine in this age group? What about lithium to prevent sort of, was that an option? What if there's prominent irritability with an SSRI? A lot of therapeutics questions.
Right.
I don't know if any one of those synthesizes into one specific, but any other therapeutic related comments that you'd want to make?
Yeah, I would say that, while I said I usually start with an SSRI and not something like lamotrigine or lithium, if the, SSRI is causing irritability, and especially if two SSRIs cause it, okay, we should go a different route. And then, with some evidence base, right, there is, what has the parent responded well to? I think especially if the parent's a lithium responder, then that may be the next direction to go. Many parents, though, don't want their child to be on lithium earlier than they need to be. And there is also that sense of, well, if they need it like if they need it lifetime and you start earlier, then the kidneys, the thyroid, all of the stuff with lithium, is more of an issue. Lamotrigine, I think, is definitely a possibility. It does not have as good a data for younger people with bipolar disorder as opposed to adolescents. That's from Bob Finley's trial of lamotrigine, but it is one of those that has fewer side effects. So if it does work, that's great. You're not getting the side effects of the atypicals. But yeah, it really is on a case by case basis. I think that my major take home though is not jumping to all of those, because some of these young people do respond well to antidepressants and therapy. We need
And
therapy.
therapy, yeah, I mean, really interesting. And I think I'm looking forward, as I imagine many people are, to results of this trial you mentioned at the end. Well, Dr. Aikman, here we are just at 1 o'clock Pacific. I want to thank you again for presenting here in our Grand Round series. Thank you for making the time and for doing this today. We really appreciate it.
Yeah, well, thank you for the invitation. And if anyone does have, questions, you're welcome to email me and I will, I can respond. So, because I feel bad we didn't get to all of these questions, but.
Well, I think a sign of the level of interest. Thank you again. And we'll end it there today. So.
All right, sounds good. Take care, everyone. Have a good weekend.